Hello, my name is Caitlin Krupp. I'm a P4 student at Auburn University on rotation in the NICU, and today I'll be talking about persistent pulmonary hypertension in the newborn, or PPHN. First, I would like to give a little bit of background on fetal versus postnatal circulation. In a fetus, circulation operates in parallel directions where the placenta is the fetal organ of respiration and the right ventricle is dominant. Fetal lungs are bypassed by two channels. The first one's going to be the foramen ovale, which connects the right and left atria, and the second is the ductus arteriole, which connects the aorta and the pulmonary trunk. Oxygenated blood is delivered from the placenta to the right side of the heart. Blood shunts from the right side of the heart to the left side via either the foramen ovale or the ductus arteriole. Once the baby's born, circulation switches to where it operates in a single direction in series. Unoxygenated blood enters the right side of the heart and is pumped into the lungs, which is the organ of respiration. Oxygenated blood then enters the left side of the heart and is pumped to the rest of the body. No mixing of blood occurs between the left and the right sides of the heart. Fetuses have an increased pulmonary vascular resistance compared to newborns due to the mechanism of circulation and relative hypoxemia. After birth, neonatal peripheral vascular resistance gradually reduces while the systemic vascular resistance increases. The failure of the peripheral vascular resistance to decrease leads to persistent pulmonary hypertension of the newborn. Some factors that decrease PVR include the expansion of the lungs, establishment of adequate alveolar ventilation and oxygenation, and successful clearance of fetal lung fluid. Some factors that increase systemic vascular resistance include the removal of the placenta, the catecholamine surge associated with birth, and the relatively cold extrauterine environment. PPHN is caused by three main categories of abnormalities: underdevelopment, maldevelopment, and maladaptation. The first one is underdevelopment abnormalities, which are determined by the reduced cross-section of vasculature, which leads to an increased elevation in PVR. Postnatal adaptation mechanisms are limited in this category, which leads to newborns with underdevelopment abnormalities having the highest mortality rate. Some conditions that lead to underdevelopment abnormalities are congenital diaphragmatic hernia, pulmonary hypoplasia, and intrauterine growth restriction. Maldevelopment abnormalities occur when the lungs are normally developed but are affected by an abnormally thick muscular layer of pulmonary arterioles that extends into the small vessels. These small vessels don't normally have muscle cells. This category includes patients with idiopathic PPHN, since postnatal remodeling of the vascular bed usually occurs 7 to 14 days after birth, leading to a gradual reduction in PDR. Some conditions that lead to maldevelopment abnormalities include post-term delivery, meconium staining, premature closure of the foramen ovale or ductus arteriosus, and meconium aspiration syndrome, which is the most common cause of PPHN. It's usually a result of airway obstruction, inactivation of surfactant, and chemical pneumonitis. Other risk factors of MAS include asphyxia, pneumothorax, and change in fetal heartbeat pattern. The last type of abnormality is the maladaptation abnormalities. These are conditions that lead to active vasoconstriction, which lead to a persistently elevated PVR. These include perinatal depression, pulmonary parenchymal disease, and bacterial infections, particularly group B strep infections, because the bacterial phospholipid in group B strep infections can activate vasoactive mediators and induce vasoconstriction. Listed here are some maternal and infant risk factors of developing pulmonary persistent hypertension. These include a preconception BMI of over 27, diabetes, asthma, or maternal use of some medications such as NSAIDs. Some risk factors in infants include males, infants born by cesarean section that don't go through the labor process, large for gestational age, and group B strep infection. Next are some clinical features that you might see in a newborn with persistent pulmonary hypertension. The first is signs of respiratory stress within 24 hours of birth. These include tachypnea, retractions, grunting, and cyanosis. A low APGAR score and early delivery room interventions, including intubation, bag and mask ventilation, or additional oxygen requirements may also be seen, along with meconium staining of the skin and nails. Diagnosis can involve a variety of tests. So PPHN is characterized by hypoxemia that is non-reactive to supplemental oxygen. So for a hypoxia test, an infant is placed on 100% oxygen, and if the partial pressure of oxygen does not increase, the test is indicative of PPHN. Next is the simultaneous pre- and post-ductal arterial blood gases, which detects right to left shunting across the pons ductus arteriosus. An arterial blood gas is obtained from the right radial artery, which is preductal, and either an umbilical artery catheter or a posterior tibial artery, which is postductal simultaneously. A higher partial pressure of oxygen in the right radial sample by about 20 millimeters of mercury is indicative of right to left shunting. Next is a chest x-ray, which is useful in suggesting or ruling out diagnosis instead of just confirming persistent pulmonary hypertension. Next is an echocardiogram, which plays a key role in diagnosing and managing PPHN. A diagnosis is not certain until predominantly bidirectional or right to left shunting is confirmed by echocardiogram. Echocardiogram also rules out structural heart disease, determines the predominant direction of shunting at the patent foramen ovale and patent ductus arteriosus, and assesses ventricular function. So how do we determine the severity of persistent pulmonary hypertension? We use the oxygenation index to determine the severity of hypoxemia, and it also helps guide the timing of interventions. It's calculated based on the infant's mean airway pressure, oxygen concentration of supplemental oxygen, and partial pressure of oxygen. So if you have an oxygenation index of less than 25, you have mild to moderate disease, and generally supportive care is often adequate to handle these newborns. If you have an oxygenation index of over 25, the infant's considered to have severe hypoxemic respiratory failure, and more invasive interventions are usually required. So the goals of therapy are to restore normal cardiopulmonary adaptation and to limit cardiopulmonary injury. So how do we manage it? So generally, supportive care is indicated for all patients with persistent pulmonary hypertension. Treatment consists of the following: treating the underlying etiology, maintaining normal systemic blood pressure, and maintaining adequate tissue oxygenation. So we're going to move into some pharmacologic therapy used for persistent pulmonary hypertension. The first one is inhaled nitric oxide. Overall, nitric oxide leads to smooth muscle relaxation. Since the nitric oxide that we use is inhaled, it's a selective pulmonary vasodilator that decreases the pulmonary artery pressure and pulmonary to systemic arterial pressure ratio. This improves oxygenation due to vasodilation in less ventilated parts of the lung, leading to blood redistribution and reduced intrapulmonary shunting. In late or preterm infants with persistent pulmonary hypertension, inhaled nitric oxide should be initiated when the oxygenation index is greater than 25 or when the partial pressure of oxygen remains less than 100 millimeters of mercury when the patient is receiving 100% supplemental oxygen. It should be initiated at doses of 20 parts per million, but doses can be increased briefly to 40 to 80 parts per million if patients do not respond to initial doses. So improvement in partial pressure of oxygen or oxygen saturation is seen about 15 to 20 minutes after initiation of the inhaled nitric oxide, and you should wean inhaled nitric oxide when oxygenation improves. The required supplemental oxygen is lowered and the infant is stable. Next is extracorporeal membrane oxygenation, or ECMO, which technically isn't a pharmacologic treatment, but it's the ultimate rescue therapy for persistent pulmonary hypertension. The goal of ECMO is to maintain adequate tissue perfusion. It's used when the oxygenation index remains over 40 despite treatment with inhaled nitric oxide and mechanical ventilation. And candidates for ECMO include infants that are greater than 2 kilograms, they have no contraindications to heparin, and they have no non-survivable congenital abnormalities. The next pharmacologic treatment is sildenafil. It inhibits phosphodiesterase 5, which increases the availability of cyclic GMP, resulting in smooth muscle relaxation and vasodilation, ultimately reducing PVR. Usual dosing is 0.5 to 2 mg per kg per dose every 6 to 12 hours. You can use an increased dose of 3 mg per kg per dose every 6 hours in term and postterm neonates. There is an increased risk of mortality with the long-term use of high-dose sildenafil, so monitor each patient for adverse effects and utilize the lowest effective dose. Sildenafil is an option when inhaled nitric oxide is not available or when infants don't respond to adequate doses of inhaled nitric oxide. Milrinone is another medication that can be used in persistent pulmonary hypertension. It's a phosphodiesterase 3 inhibitor, which increases the availability of cyclic AMP, reducing left ventricular afterload and causing peripheral vasodilation, leading to a reduced PVR. Patients receive a loading dose of 50 mics per kg over 1 hour, followed by a continuous infusion of 0.3 mics per kg per minute, titrated up every 2 hours as needed to achieve the desired effect, or a maximum dose of 0.99 mg per kg per minute is reached. We use it as an adjunctive therapy with inhaled nitric oxide, and it's showed to improve oxygenation. Some studies show that the use of surfactant decreases the need for ECMO, shows an improvement in oxygenation, and a decrease in mean airway pressure. These studies have variable results, which may benefit select groups of infants with persistent pulmonary hypertension. The use of surfactant has also been shown to decrease air leaks, length of stay, and pulmonary morbidity in infants with meconium aspiration syndrome and pneumonia. These studies fail to show long-term impact on duration of mechanical ventilation, use of inhaled nitric oxide, and length of stay. Prostaglandin analogs cause systemic pulmonary vasodilation. Data is limited to case reports that show that inhaled prostacyclin I2 and iloprost can be beneficial in infants with PPHN. More studies are going to be needed before they're recommended for routine use. Lastly, bosentan is an oral non-selective endothelin-1 receptor antagonist. It's an attractive option when inhaled nitric oxide and ECMO are unavailable, as it has been shown to be more effective in improving oxygenation indexes and oxygen saturation, as well as decreasing time of mechanical ventilation when compared to placebo. Short-term safety outcomes were promising, but long-term safety data is lacking. To administer, do not crush the tablets, but dissolve them in 5 to 25 milliliters of water. I wanted to point out some outcomes of note. Importance regarding not only pharmacologic therapy, but also for those for pulmonary hypertension itself. Firstly, inhaled nitrous oxide. It does not appear to cause long-term adverse effects and has been evaluated in multiple follow-up studies. Other persistent pulmonary hypertension treatments have limited long-term safety data. Survivors of severe persistent pulmonary hypertension and/or ECMO treatment are at an increased risk for developmental delay, feeding problems, short-term respiratory morbidities, motor disability, and hearing deficit. So some key takeaways from this presentation are that persistent pulmonary hypertension of the newborn is a neonatal emergency. Management consists of general supportive cardiorespiratory care, treatment of underlying pulmonary conditions, and pharmacologic treatment as needed based on severity. These treatments include inhaled nitric oxide, phosphodiesterase inhibitors, prostaglandin analogs, endothelin receptor antagonists, and ECMO. Pharmacological treatment lacks high-level data, so the best way to manage persistent pulmonary hypertension has yet to be determined. For these patients on pharmacological treatment, you want to monitor them closely for adverse effects. Long-term follow-up after discharge from the NICU is necessary. Thank you for listening to this presentation. I hope you have a great day.